Cough seems simple, but it's one of the easiest ways to miss something dangerous, especially in kids, because a cough could be from a mild viral illness, due to reactive airway problem, or an airway emergency. And many students approach cough by trying to memorize long differentials, but experienced clinicians don't do that. They start with pattern recognition. In this video, I'll show you the ScrubNotes clinical framework that helps you go from confused and unsure to a focused diagnosis in just a few steps. At ScrubNotes, we approach every chief complaint the same way. First, safety. Could this be dangerous? Second, we look for patterns. What clues narrow the possibilities? And third, we use key diagnostic forks as decision points that guide what we do next. That's the approach we'll use for a case today, and by the end of the video, you'll have a simple algorithm that you can use to take any cough case and narrow it to a short differential quickly and confidently. When a parent says, "My child has a cough," that can mean many different things. So the first step is clarifying the pattern. We want to ask a few key questions that will do most of the work for us. Is it acute or chronic? Is it dry or productive? What does it sound like? Is there any fever? And were there any choking episodes? And at the same time, we're always wanting to screen for red flags. So we want to check for things like respiratory distress, hypoxia or cyanosis, stridor, and sudden onset. Because in peds, airway problems can escalate quickly. So the goal here is simple. We want to rule out dangerous causes first before we start narrowing our differential. So let's dive into our case of a 4-year-old boy who presents with cough. At first, cough feels like a huge list of differentials, but clinically, most cases fall into just a few buckets. We have infectious causes, airway causes like asthma, there could be upper airway issues, or mechanical causes like a foreign body. So you don't need tons of diagnoses, you just need to identify which bucket you're in. So let's begin by asking our patient some focused history questions. We'd want to start with the timeline. So when did the cough start? Is it acute? So it's been going on for less than 3 weeks. You could have causes such as infection, croup, or a foreign body. Or if it's a more chronic cough lasting 4 weeks or more, you might want to consider asthma, upper respiratory issues, or GERD. Next, you'd want to ask about the character of the cough. If it's a dry cough, you might be thinking asthma or GERD. If it's more wet and productive, this could be indicative of an infection or protracted bacterial bronchitis. If it's more of a barking cough, you'd be thinking croup. And if it's paroxysmal or whooping, pertussis is more likely. Next, I'd want to ask when it occurs. If it's at nighttime, that might be indicative of asthma. Or if it's more after meals or lying down, GERD's likely. And then if there's exertion, asthma is also a possibility. Next, you want to check for any associated symptoms. So are they running a fever? Then you'd be suspecting infection or upper respiratory infection or pneumonia. If there's wheezing, you'd be considering airway obstruction. If there's stridor, upper airway issues like croup. And if there's rhinorrhea or congestion, maybe more of a URI. And then don't forget to ask about any red flag or concerning questions, like if there was a sudden onset, that's more likely from a foreign body in kids. If there's respiratory distress, you could have severe airway disease. Any cyanosis, that's indicative of hypoxia. Hemoptysis would also be a serious concern. So if yes to any of those, you'd probably want to refer for a more urgent evaluation. So now that we've asked those questions, let's revisit our case presentation. We have a 4-year-old boy who presents with cough for the last 5 days. Cough is worse at night and is described as barking. He has had a low-grade fever and a runny nose for the last 2 days. His parents note noisy breathing when upset. There's no choking episode, and he's up to date on vaccinations. Here's the algorithm I use to approach cough. I'm basically first checking for red flags. So if there's any kind of acute distress in the airway, there's signs of hypoxia, I'm going to have an ED referral. But let's say we ruled that out, then I'm going to use time as my next big diagnostic fork. So whether it's acute, it's been going on for less than 3 weeks. If there's barking and stridor, I'm thinking croup. If there's fever with a wet, productive cough, infection's more likely. If there's sudden onset, that could be more indicative of a foreign body. If there's wheezing, asthma or reactive airway is more likely a cause. And then again, using time to help distinguish our fork here, if it's more chronic and greater than 4 weeks, Again, we would ask, is it wet and productive cough? That's more likely protracted bacterial bronchitis. If it's dry cough and occurs at night, asthma could be a cause. If there's throat clearing and congestion, maybe postnasal drip. And lastly, if they have it after meals or lying down, you'd be thinking more GERD. GERD's less likely in a 4-year-old, but just for thoroughness, I've included it here. Okay, let's refine our initial differential list. So given this history, I think there's acute onset, barking cough, URI symptoms, and no choking. So upper airway pathology moves to the top for me. Still could have pneumonia, asthma, or a foreign body, but I think those are less likely at this point. Now that we've asked focus history questions, our PEs are going to be informed by that information and much more targeted approach. Don't forget to check your generals, look for any kind of work with breathing. Also, be sure to gather vitals, especially in an OSCEs. Let's look at the table here of physical exams we might want to perform. So if we were suspecting an airway obstruction or asthma, that would be indicated by episodic cough. There'd be triggers, especially at nighttime. So definitely want to do a lung exam and examine forced expiration. So for our patient today, let's say that there was no wheezing and this was negative. If there was something like pneumonia, there might be more fever or wet cough. So lung exam, we definitely want to make sure we auscultate and percuss the posterior lobes. Vitals, again, are important here. So for our patient, let's assume there was no crackles or dullness, and this is less likely. If there was infection, maybe croup, there'd be a barking cough, it's worse at night, and maybe a recent upper respiratory infection. So we definitely want to check lungs, listening for stridor, look at those accessory muscles for breathing. You'd want to auscultate the neck, and of course vitals. So for our patient, let's say there was stridor and plus or minus some retractions. Foreign body aspiration as a DDX, that would be a sudden onset, but there'd be no systemic symptoms. So again, lung exam is probably warranted. I'd also want to check nose and throat. So for our kiddo today, let's assume they had symmetric airway entry and everything was within normal limits. And then lastly, if you wanted to check for postnasal drip, there might be cough or congestion. And again, lung exam, pretty critical for this case. But you'd also want to check nose and throat. Maybe there's some mild upper respiratory findings, but again, probably not likely for our patient today. So I wanted to connect the cough patterns with your initial evaluation, especially for pediatrics. So you're basically asking, is this an upper airway problem, a lower airway problem, or a fluid problem? So you'd want to start with the sound. So if there's barking, think croup. If it's wet, think infection. If it's a dry cough, asthma is more likely, sudden onset, foreign body. And then you want to refine your exam. So if there's wheezing, that's more likely for narrowed path airways. There's crackles, that means there's fluid, and a stridor, then upper airway obstruction. So the key here is the sound of the cough often tells you where the problem is located. And I've also included a summary table here of lung sounds just to have as a quick reference. Okay, let's put everything together here into an assessment. So we have a 4-year-old boy who presents with a 5-day history of cough that is worse at night and described as barking, followed by a recent URI with low-grade fever and rhinorrhea. His parents report intermittent noisy breathing when he's upset. There's no history of choking, foreign body aspiration, or chronic cough. On exam today, we found the child appeared non-toxic with normal oxygen saturation, mild increased workflow of breathing when agitated. Lung exams revealed inspiratory stridor without wheezing or crackles, and breath sounds are symmetric. There are no focal lung findings or signs of lower respiratory tract infection. So the acute onset following a viral prodrome is pretty characteristic barking, cough, and presence of stridor are most consistent with croup. Alternative diagnoses such as pneumonia, asthma, or foreign body aspiration are less likely, given the absence of fever with local findings, wheezing, or sudden onset. Before we finish, here are 3 common mistakes students make with a cough chief complaint. First, skipping severity assessment. If you don't assess work of breathing or stridor, you can miss an airway emergency. Second, ignoring physiology. So not distinguishing stridor from wheeze from crackles can lead to incorrect diagnoses. And third, Missing pattern clues. If you don't ask whether their cough is barking, wet, or dry, you want to make sure to check for acute versus chronic and understand if it's a sudden onset, the timing. Otherwise, if you don't ask about these, you lose your strongest diagnostic tool. If you can avoid these common traps, then cough becomes much easier. To summarize the ScrubNotes framework for cough, first, we want to rule out dangerous causes. Second, we want to identify the pattern. So remember, its classic pattern of barking cough with an URI and stridor is indicative of croup. And then third, we want to use those key diagnostic forks to help us narrow down our differentials. So if there's stridor, think upper airway cause, wheezing, asthma is likely, crackles, indicative of pneumonia, sudden onset in peds, we'd be thinking of a foreign body obstruction. So once you start thinking about cough this way, the entire evaluation becomes much more manageable. If you found this helpful, check out the rest of ScrubNotes Chief Complaint Series, where we break down other common presentations using the same organized framework. Thanks so much, and I'll see you in the next one.